Hello and a very good afternoon, everyone. COVID-19 may develop in children without any signs or symptoms. But at the same time, some children can experience milder symptoms, including low grade fever, tiredness, or cough. So, to prevent disease exacerbation, it is essential to be aware of the accurate diagnosis, pathophysiology, treatment, and management of COVID-19 in children. So, to talk about that, we have with us Dr. Amitav Banerjee. Welcome, sir.
Thank you. Welcome.
Dr. Banerjee is a professor and head and clinical epidemiologist at the Department of Community Medicine at Dr. D.Y. Patil College in Pune. Formerly worked as epidemiologist in AFMC, Pune, leading the mobile epidemic investigation team of the Indian Armed Forces. He investigated and published original research of different outbreaks in many parts of the country, including tribal areas. So over to you, sir. You can begin your presentation.
Okay, thank you, Darshika. I thank Dr. Plexus to give me this opportunity to share my insights. I think I'll be just trying to give the epidemiology of COVID in children. I suppose subsequently you may have a pediatrician to talk in detail about the clinical features and management. My job is more basic, simple. How we have had this two waves we have had already. And in these two waves, we have some experience how it has impacted the children. And so far, it has been quite reassuring because the morbidity and mortality in children have been very, very minimum. There have been some deaths in children, regretfully. And of course, there are data from Western countries where they have a better data system. But most of these children were already having comorbidities, like childhood leukemias, obesity, endocrine disorders. So there have been almost zero deaths or negligible deaths in children who are healthy. So that should be quite reassuring to us. On the other hand, their measures have been quite distressing to children. I mean, it has been particularly the closure of schools for almost 2 years now. So now there have been certain reports which are coming up that it is adversely affecting the mental and social health, because children is the time when they really develop the social skills, psychological skills, educational skills. The learning curve is very sharp in children. So it has been a major setback. And now we are in a dilemma whether to open schools or not to open schools. And this recent variant, that is Omicron, it is very contagious. So it is giving a fresh fear among the people, among the parents, and the dilemma. And but fortunately, this Omicron is very mild in adults also. So we expect that since the earlier more virulent variants were mild in children, Omicron will have hardly any impact on children. So with this encouraging note, we can proceed. And another dilemma is whether to vaccinate children or not to vaccinate children. The vaccine among parents. So they are quite, because these are new vaccines and it has been rolled out so fast, and the vaccine has been approved for 15 to 18 years age group. Of course, it is a vaccine which can be taken up to choice. Of course, there have been too much of a momentum to spread, to introduce this vaccine very fast. But it is a matter of choice as far as the official position of the central government is concerned. Of course, individual risk has to be weighed, and the personal pediatrician or the physician can decide. So that, of course, we can leave it for the next session. But today I will just give an overview of the impact. So this is the children have been quite, has been a major setback for children, and particularly with the closure of schools. And COVID-19 and children, basically, whether COVID, while COVID has been very mild on children, the virus, but the measures have been quite prolonged. And this concerns for COVID, basic concerns which all parents will be having are whether the children are at high risk. That is whether the children, it can cause some unfortunate deaths or some disease which is severe. Second concern for the planner, for the policy planner, can be whether the children may themselves not suffer but can they spread it to the elders in the house, to their parents or to their grandparents? So that has been one concern. And the third concern, definitely this is for, again, the planners is, and the policymakers is whether opening of schools will trigger community spread. It will trigger population spread. So these are some of the dilemmas, ethical dilemmas. And I must acknowledge here, before I proceed, all these sketches have been drawn by Professor Bhaskaran Raman of IIT Mumbai. So with his kind permission, I am using his sketches. In fact, you will find them more interesting than the actually content. Conveys a lot of dilemmas. Ethical dilemmas is whether to save one child, you are harming so many child by closing of schools. So this is one of the ethical dilemma. So the three questions in the parents' mind, all three, we have got some studies which are published studies, which are quite reassuring. So mortality and mobility among children. So the mortality and mobility, they have done studies. There was one country which did not close the schools throughout the pandemic. That was Sweden. So Sweden, throughout the pandemic, of course, Sweden is a very small country, just a population of 1 crore, but even we can use it as a natural experiment. So during the whole pandemic, there were hardly any morbidity, excess morbidity or mortality among the Swedish children, school children who went to schools throughout the pandemic. Only 15 cases were admitted to ICU. 7 had multi-inflammatory syndrome, which is the dreaded complication in children. And all of them survived. And out of the 7, 4 of them are having some comorbidities. So Sweden experience was very encouraging. There was no excess morbidity or mortality among the school teachers also compared to previous year. So that is quite reassuring. Besides that, they did a study of among 7 countries in Europe to find out the combined 7 countries, the mortality or different causes of death during the height of the pandemic in the first wave, where the Europe was very badly affected. How many children died of pandemic compared to other conditions? So they found only out of total deaths in children, only 0.3% were due to COVID and 99.7% were due to other causes like accidents, other respiratory infections, and other childhood conditions. So COVID contributed very little to child mortality during the height of the pandemic in Europe. And this is the age-wise survival rate. This is a meta-analysis, a pooling of many studies by one of the authors is John Ionitz. He's a leading epidemiologist from Stanford University. So age-wise, after the child, age-wise survival rate after getting the infection. These include the asymptomatic cases, and these are projected from serosurveys in the community. Because symptomatic cases or contact tracing, only 5% of the cases are detected. 95% cases are missed, which are estimated by serosurveys. So if you increase the denominator of all the infections, if you see up to 19 years of age, the survival rate is 99.9973. This is a published study. We'll give the reference. And even right up to the 69 years age group, the survival rate is 99.41%. So it is quite reassuring this way. And particularly for children, the discussion today. And whether, second question is whether children transmit to elders, and that also the study is published in Pediatrics, International Journal of Pediatrics, that 90% of the times children acquire the infection from adults. It is not the other way around. So for policy reason, for all practical purposes, we can say that children are not a risk to adults. And particularly in our country, when we did the sero survey, recent sero survey in Delhi shows 97% of adults already have antibodies, showing that they are got some protection, and 80% of children have got the antibodies. So there is the spread of infection has been almost equal among the children and adults. And at at the present time, the children do not pose any risk to adults from the own data also. And they have done other studies in Europe where they found that keeping the schools open did not trigger community transmission. So this is somewhere which is unique for COVID. Whereas in influenza, the schools have been responsible for spreading community transmission, for triggering community transmission. So it is unlike this. It is in COVID, the school children do not trigger community transmission. And the downside, if you see on the sketch, the downside, the collateral harm of closing the schools are child labor has increased, poverty, malnutrition. Many children get the midday meal in schools, poor children, mental harm and illiteracy. And the myths, these were the myths that schools are super spreaders, children are at high risk, children need a COVID vaccine, which should be offered to children who have got comorbidities, that perhaps the pediatrician risk. And the third wave, since the past 6 months, we were anxious about the third wave. We are apprehensive about the third wave. So which again, it has shown that the pediatric age group has not been impacted. Even presently, we are having so-called third wave by Omicron, which is very mild. So it is 10 times milder than the earlier variant. So if we have seen the data from the survival rates, 99.9973 was the survival in children from the previous variant. That studies were done previously. So you can say with Omicron, which is 10 times more mild, it would be almost 100% survival. So there is no cause for worry of parents, but we can just watch as it unfolds. And this open schools, this is the published study, New England Journal of Medicine. Unvaccinated children are not at high risk group. And despite students having kept schools pre-open, we found this is as the study I was quoting. So this has been published in the New England Journal of Medicine. There were not very few cases. One child in 130,000 children were admitted in ICU. And that, as I said, total 15 children were admitted in Sweden and all survived. So, of course, Sweden is a very small country, but still that can form a part of a natural experiment, like initial trial. So, it is quite reassuring. And this, as I said, this is the reference I said I will show you that COVID transmission to children, the child is not to blame. This is again a study published in Pediatrics. We have done contact tracing, so they have tried to trace which way the infection transmission has moved, the direction of the transmission. They found the majority, most all the children, they got the infection from the adults. Very few adults got the infection from the children. So this concern that if you open the school, children will bring the infection and spread it to adults, this does not is not confirmed by the published literature. So there should be a strong case for opening of school now, given this data. Effects of online education, a lack of interest, stress, Zoom fatigue, eyesight, and vitamin D, physical activity. The children are losing physical activity, and 2 years, say a 5-year toddler, 2 years of 40% of his life is spent indoors. And there would be long-term mental and social setbacks. There will be long-term mental, etc. Are we going to stop children? They are not vaccinated. See, you see, okay, 15 to 18, they have started the vaccine, but what about children below 15? We should open the schools. We should not wait for the vaccination right to up to 2 years of age or 5 years of age, because they are not at risk. Even 15 to 18 years also, they are not at risk, we have seen from the data. So these are the learning gap. These are the impact of the more measures, more harm has come from the extra cautious measures, or due to panic or fear, or not knowing about the epidemiology of COVID, pediatric epidemiology of COVID. But now over the 2 years, we have got enough data to be very certain that the children, it is not going to harm the children. This virus is very mild in the children, and even if the previous viruses were mild. This virus, Omicron, is the 10 times less virulent. So, and there are other reasons also, physiological reasons for this virus not causing much symptoms in children. The physiological reasons are this: the virus does not infect the lungs of the children, because the pediatric group, they lack the ACE receptors. ACE receptors on which the virus latches. So the children are deficient in ACE receptors. So the virus doesn't have something to latch, the receptors to latch on in the pediatric age group. Secondly, they have got a very active thymus gland, so which is responsible for good T cell and cellular immunity. And thirdly, the children have got a high melatonin level. So all these three factors, it protects the child from the adverse impact of the virus. So there is a physiological reason, and which is borne out by the epidemiological data from published studies in at the community settings. And so therefore we have to be quite confident, optimistic that we can, the children can lead a normal life. Sooner the better. And the other thing that we cannot, particularly in our country, we are all adults and children also, they are exposed to other conditions. Particularly malnutrition in children is very common in India, particularly and if too much of lockdowns and other closure of school, as I said, is aggravating the malnutrition. I say many children are getting the midday school meal in the schools. So it affects the malnutrition, which will bring down. Secondly, we have got other communicable disease like measles. Measles is has a higher impact on children. COVID has no impact on children. Then we have got dengue fever, dengue seasonal. We have got typhoid, which kills 3% even after treatment. We have got tuberculosis, and in India we have got 2,000 children die every day in India from preventable causes: diarrhea, respiratory infections, malnutrition, under a background of malnutrition. So comparatively, if we focus only on one disease, we may be, as it is not affecting children disproportionately, but we will be neglecting other killers in children. Like I said, dengue, typhoid, Japanese encephalitis in parts of India, scrub typhus, then measles and other respiratory infections. So therefore, this poverty, malnutrition, child labor, and keeping the mental harm, illiteracy, child marriage, the cyclone may come, we cannot take risks. So as I said, this anxiety about the pediatric third wave the events did not work out that way. We did not have a third wave. And then, of course, this some debatable things are require further research, because this spike protein on the coronavirus is something which has become concern. They are particularly the vaccine spike protein also. Luckily, we are not having this mRNA vaccine in India in the pediatric age group, but there are concern, like whenever we are talking now about the discussion which bound to come around the vaccines for children, whether they require vaccines or not. So the Western countries, many of the Western countries, they are giving the mRNA-based vaccines. And the reports, there have been published reports that there have been increased rate of myocarditis in children, particularly in male children, the myocarditis, inflammation of the heart. So that is a matter of concern that requires more research. So in our country, the vaccine for children is the Covaxin, but perhaps, hopefully, the adverse effects may be less. But that also has got, we require a better monitoring and a very, very judicious use of vaccines in children. And the risk-benefit calculation has to be worked out more rigorously. We should have a good system of adverse events reporting. So parents should be aware, if they opt for vaccination, they should be aware of how to monitor the child for any adverse events and where to report. So without this it would be not advisable without a proper monitoring system in children to go for this. So this is, as I said, there have been certain concerns. There are certain, actually the debate has got polarized. So since this is a platform of professionals, so we have to not believe either view blindly. We should do more research. There are certain views on extreme that vaccine big mistake or dangerous. Then there are other views that vaccines are very essential. So these are the two extremes. So as a professional platform, we should examine the data, ask for the data, and come to our own conclusions. And as I said, a very good monitoring system. So we should not blindly believe they are the best option or they are the worst option. So this has been so fast, this pandemic has progressed, and the measures have also progressed so fast. So 2 years into the pandemic, it is time to pause, take a breath, and ask for more data. As professional group, we should do more research and resolve the issues, resolve the concerns, neither accept them, neither reject them, but investigate them. So as I said, had nanoparticles can, of course, this traveling this spike protein or the vaccine particles, it can be due to wrong injection practices also. So there is there have been more cautionary information that the vaccination technique should be proper, that you should aspirate to, so that it should not go into a blood vessel. If it goes into a blood vessel, there is a chance of more adverse effects. So that vaccination technique should be proper, so that the side effects are prevented. And besides that, also we require a long-term monitoring system, because no vaccine has been, again, these are again extreme views. This is Robert Malone, who is an investigator of mRNA technology. He has got concerns that these particles can go into the organs. So again, as I said, this we cannot accept it blindly nor reject it blindly. We require more research on this to rebut it with data, or to caution it if there is some real truth in that. Truth is only by research, not by opinion. So this are some of the concerns. And another concern is, of course, none of the vaccines have undergone a long-term trial, because the vaccines are there for 1 year, 2 years. So concern raised can cause, as I said, myocarditis data is indicating there is a strong signal in Western countries, particularly from UK baseline data in children. Blood clotting and bleeding disorders also have been even, or this AstraZeneca and other Covishield, there are reports of blood clots in a very small, rare. These are rare side effects. And there other limitation is the long-term adverse effects. We do not have data because we have to follow up. So that way we should have a very good monitoring system. And when we are contemplating vaccine in children, this becomes very important, because in adults, elderly person, the long-term effects may not have such an adverse impact. But if the child has a life to lead it, particularly if it has got myocarditis or something, it has got we don't know. It may resolve completely, or it may have some residual impact. So vaccines, like any intervention, whether it is a drug or even a vaccine, I think can have. So for that, we require a very strong surveillance system. So low risk children, again, these are all, we have to, again, we have on data, and we have to just, particularly the younger the child, the lower the risk. And therefore, high risk children can be given focused prevention, including vaccination with, say, comorbidities or certain endocrine disorders, obesity, which are the risk factors. And there have been adverse event reporting, adverse drug reaction. Why is it reporting? Some scenarios at first vaccination drive. So these are some of the, this is published recently in British Medical Journal. that there have been certain instances where the adverse effects following this vaccination drive were not followed up. So this has been, besides the concerns raised by certain, one would say, whatever fringe group, because anyone who is doubting this is being labeled as a fringe group, but it has been published in a prestigious journal, British Medical Journal. Therefore, as I said, as a professional group of docplexers, as doctors, we should take a scientific view and investigate in a scientific manner with proper data, proper observation, proper autopsy also if required, proper histopath examination or whatever the concerned specialist. So these are the state committee, district committee, healthcare providers. These are all very good on paper, but we know, because we have never gone for such a large scale vaccination program. So our health infrastructure or may perhaps is not is not adequate to keep up pace with the vaccination drive. It is like, we are trying to run a super fast train on tracks which are not complete or tracks which are very old. So this is given a public health system. If you try to roll out a vaccination drive at a very rapid pace, we should have a good monitoring system, which are the tracks of a super fast train. So these are some of the things which are to be looked into, because as I said, there is a scientific part which should look onto the adverse effect, and there is an administrative part, logistics. We should know whether we have the logistics to make it a safe program. So reality, as I said, we don't have how to report, the reality of reporting. So to conclude, children are themselves do not suffer, and they are not super spreaders also. The 2 years data indicate they are not super spreaders. Mortality in children are almost nil for as far as healthy child is concerned. But there are concerns that side effects, the data shows that mortality in children are 2 in 1 million, whereas the adverse effects are 10 times more, 10 in 1 million. Out of 10, there may be 1 or 2 deaths. So as far as mortality is concerned, it is almost, there is no, very difficult to, particularly the younger the child without comorbidity, it is just neck to neck. Long term, we do not know. Other killer illnesses are being neglected. Research on such illnesses advance same attention. So we require, this is a wake-up call. COVID has brought attention that we should have similar monitoring system of counting the cases and mortality for all our diseases. As I said, 2,000 children die every day from India. 1,400 people die from tuberculosis and other diseases. We don't have good data. And these are what I had to say. These are the references and of vaccine. There are all types of views. Some are extreme, some are balanced, some are here. So as a independent or detached view, scientific view, you have to take. And this is all I think I had to discuss. And now any questions or any doubts, we can take over.
Thank you so much, Dr. Banerjee. Very well explained lecture. We do have a couple of questions, and starting from immunocompromised children. So how about COVID-19 vaccination for such children? What do you have to say about that?
It is a really, it would be a professional dilemma as well as a parental dilemma, because on one hand, immunocompromised child is at a higher risk, like any from COVID. And another, the vaccine, the response to the vaccine, the antibody response to the vaccine also may be compromised, because you require a healthy immune system to kick on the antibiotics as a response to the vaccine. So this requires expert monitoring by the pediatrician or by the immunologist, because you have to see each child's, because there may be different degrees of immunocompromise. So these requires customized and tailor-made that firstly they may be at higher risk of COVID, and you have to see other risk factors, whether the child is obese or just immunocompromised child is obese, or child is having any congenital heart disease, or whether child is having type 1 diabetes. You see, if you control the other risk factors, they say obesity, diabetes, and other comorbidities, it gives 70% protection from COVID. So it is as good as getting a vaccine. And with that thing, judicious use of vaccine can be considered mindful. And of course, there is no harm in perhaps giving a vaccine to them, but we have to just monitor the antibody response. So we can
go ahead with the vaccine.
We can go ahead with the vaccine, and we can just see how well the child has developed antibodies. But again, I think even they have done, they have published papers also that they have found that unlike the adults who are immunocompromised adults or who have got comorbidities, children with comorbidities, which includes immunocompromised children, they are lesser risk compared to a child, to an adult, compared to an adult with comorbidities. So children across the year, even an immunocompromised child fares better because, as I said, the child may be immunocompromised, but child doesn't have ACE2 receptors physiologically. So the virus doesn't get something to latch on. So even an immunocompromised child, a child with comorbidities are better protected from the adverse effects of COVID naturally, physiologically.
So in case a child is infected, so Dr. Ananda Kesavan wants to know, what are the drugs that are approved for children?
As on today, mostly the drugs are only symptomatic. If there is a fever, just symptomatic treatment. You have to watch if the child goes for on the 7th or 8th day, if the child goes for cytokine storm, which is very rare in children. So that time the consulting pediatrician may use steroids and if required oxygen. So there is no specific drug as such. New drugs have come, like they say Molnupiravir and other things have come, but I wouldn't, of course I'm not a specialist, but pediatrician will know better, but they have got side effects. In fact, they have got side effects of which particularly in children it should not be advisable, because even in adults they say don't conceive or something, so it can affect the ovaries and testes, so which in children one should not. So as I said, most of the children will be no specific drug will be required. Many drugs have been advocated, but when a disease which has got such a low mortality, say in children the mortality is 1 in 1 million.
Correct.
So it's difficult to evaluate which drug is working or not also.
Correct.
Because you see, in 1 million only one child will die, 1 million will survive. So how will you evaluate any drug? So it is the management of any, say, respiratory embarrassment or oxygen level. So for which there is it's an autoimmune reaction. It's not due to the viral load. And so that time the steroid is the only one which has stood the test of time. And I don't think in children there is a requirement of any drugs curatively.
Okay. That brings me to my follow-up question, which is asked by Dr. Jay Gupta. He says, so are Nsaids like Manic Acid or Ibuprofen safe for kids during COVID-19?
There have been concerns like Ibuprofen or paracetamol also, but I think paracetamol is the safest. Ibuprofen and other things are not very safe, but I leave it to the pediatrician to take it further. Okay. Epidemiologists, we just count cases and analyze the data. We don't know what's happening on individual level. But by and large, to give paracetamol is the safest. Even that has been a question is there, but it is the safest. And that too, if the fever is very high. Otherwise, just supportive treatment.
Okay.
Vitamin C, vitamin D, because there are studies which have found that children have got low vitamin D level, adults have got low vitamin D, and with this lockdown and all, we are not getting sunshine. So the supportive treatment, high levels of vitamin D, high levels of vitamin C, not only as a treatment, but as a prophylaxis also. So my whole family had low vitamin D. I am on vitamin D because we have all got very low vitamin D, and we have people who are having fairly good nutrition and other things. So you can see the poor child. So when we thought we are having a good diet, but vitamin D is very low in dietary sources. So you have to require sunlight, and they have lockdown. We are not getting sunlight. So. And the children are not playing in the schools and all, they used to get a lot of sunshine. So I think vitamin D itself can act as a preventive.
So my next question is from a pediatrician, Dr. Devendra Sareen, who says, is there any relationship between pain abdomen, like pain in abdomen, and diarrhea symptoms with severity of illness in the new variant?
He is a pediatrician. He must be seeing the cases. I think he would know better. But of course, I think the new variant is having a different group of symptoms. The new variant particularly do not cause loss of smell, loss of taste. So that's all. So probably, of course, any viral disease can cause GIT disturbance. So probably this, but I think it can cause. But
and so once a child is infected, so what should be the interval where we should wait for vaccinating the adolescents or children?
Once the child got infected, as far as my opinion, again I am giving my opinion and data also. The Israel data shows that after recovery from a natural infection, the immunity is 13 times better than vaccine immunity. Okay. So I would not recommend vaccinating someone who has recovered from natural infection.
Okay. Not vaccinating at all, you mean?
Not vaccinating at all. This is the debate going on.
Okay. A couple
and
of more
80% of our children have already suffered the infection. So that leaves only 20%. So we are very safe. Our children are very safe. Even if we give 1 dose or 2 doses, they have already got 13 boosters. Because after recovery from natural infection, the Israeli studies, published studies, large data set shows that they are 13 times more robust immunity than vaccine immunity. That means they have got first 2 doses and 11 boosters. 1, 2, and 11 makes 13. So I think as Indians, whether it is adults or children, we are very well off. I'm very optimistic that way.
Okay. A couple of more questions. Now, talking from the social angle of it, we know that underprivileged children and few rural children also have lost education due to not having access to phones or finance. So what measures, according to you, should be taken by the government to benefit this mental health of such children?
Yeah, I think you require...
How to include them in the mainstream is mine.
They would require... they would require the services of psychologists, sociologists, and a lot of... they really require, because there have been domestic violence, there have been child abuse. It's not only the educational setback or social setback. Most of them may have faced. There have been reports of suicides. There have been reports of suicidal tendencies. There have been reports of child abuse. So they may be having a lot of psychological trauma, and they may be having post-traumatic stress disorders. So we are going to have a huge wave of these disorders in times to come. It's a matter of greater concern. So we require community services. We require medico-social workers. We require counseling services. We may require team approach, and a lot of investment may require. It would be quite resource intensive, and you have to get them back in the mainstream.
So my next question is from Dr. Palak Khetan. So she has a case she wants to know about. A 17-year-old male diagnosed with medulloblastoma and hydrocephalus 8 years ago, underwent surgery, chemo, and radiotherapy. Right now, he's free of any malignancy. So is it safe to give him the vaccine in such case?
That is again a 17-year-old. Again, a difficult question, and because vaccine, it may be indicated in him, but whether it is safe or not, we can. I think we can suggest that he can undergo a serological test for antibodies, say IgG antibodies. Okay. And if possible, he can also go for cellular T cell and other cells, because of course that is little costly and only in some labs, but that will show whether he has already suffered, because as I said, 80% of our children have also suffered from the natural infection. Okay. So if he has got natural immunity, that would be safer. Then of course he will become a high risk group. So as I said, there may be certain questions very difficult to bear the risk benefit. So it has to be at an individual level, whatever, how much we can investigate and tailor made. Suppose we find that he is having natural immunity from natural infection with antibodies or T cells. So I think it would be better to.
Okay. One more question. It is more of a comment. It is from Dr. Divya Markande, who's a trauma and emergency medicine doctor. She says, as per the info from the most recent AIMS webinar on COVID-19 in children, molnupiravir is not recommended for patients less than 18 years of age. So
Certainly not. As I
yeah.
said, because even in adults also, it is not very safe because it causes changes in the ovaries, gonads.
Okay.
So it is not safe, certainly not safe in children, and not indicated also. Children do not suffer from severe disease. So it is not indicated also and not safe also.
So these were the questions that I had. Majority of questions definitely ask about the mental health of such children who are in quarantine, or it's because of course it is difficult for children to maintain any kind of make them as a habit of keeping sanitary precautions. So in that case, I think a physician or a pediatrician, how should they be guiding the children or their parents, to keep proper precautions at home as well?
Precautions means what type of precautions?
So like maintaining social distancing, or if somebody is in the family ill, so how not to go, because these things children don't understand.
These are not possible for adults also.
Okay.
These are not possible for adults. These are just things which are just as rituals. They are not being maintained by politicians, their followers. Neither it is possible, and the infection has already spread through the community. And Omicron, they have conceded that Omicron can spread whatever measures you take. So I don't see the really rationale of trying to prevent something which cannot be prevented. And Omicron is very mild, and it is been said by experts also that it's going to act as a nature's vaccine.
Yeah.
So no vaccine may be required, and you cannot stop the spread by. In fact, in UK and other places, they are not for masking in school children also, because masking doesn't really prevent, and it can cause other types of cross infections, because children can hold mask whole day and are supposed to change it, and the cloth mask doesn't work in any case, and you can't have a N95 and you will throughout the day. So this masking also should be, we should do, as I said, Docplex's platform of professionals, they should really review the studies of mask or do their own studies. So the mask in children causes more harm than good, because again it affects the mental and psychological health. As you know, all children, they by facial expression and all, they socialize, they learn the language. So this will cause masking has been in children particularly, it is not indicated at all. And but still the school insists as a they feel comfortable that all are wearing mask. It's just not possible and not required also in the present phase of the pandemic, where it has spread through the community and with the present variant.
Okay. So thank you so much, Dr. Amitav, for talking to us about such a pressing issue. And with this, we would like to close today's session. So
thank you.
Dear viewers, please keep watching our webinars and keep supporting us. And if you have any more questions to Dr. Banerjee, please feel free to drop them on the comment section below. We'll reach out to him and get your answers. And we will be back with such clinically enriching sessions again in the coming future as well. So take care and have a great evening ahead. Thank you so much, Dr. Banerjee.
Thank you. Pleasure. Thank you.